Hey ladies and gentlemen, it's Bill Hinckley, current president of the Air Medical Physician Association, flight doc, and medical director at UC Health Air Care and Mobile Care in Cincinnati. And I'm going to be talking about tough airways, difficult anatomy, or difficult physiology. You guys are looking at this slide thinking, Hinckley, what is that rabbit? And I'll tell you right now, that is the lemon rabbit. And I want you to come to associate the lemon rabbit with difficult airways. We'll find out more about this guy in a little bit. If this lecture sucks, it's because this is how I spent my prep time doing rabbit research. This is the jackalope at a bar in Austin, Texas. The sign beside me, or behind me, states that it was voted the best bar in America. And I'm not sure about that, but it was a pretty good bar. Alright, I've been doing this a long time. 12 years down, 38 to go. That's the plan. When it comes to airway management, I stand on the shoulders of giants. Most of them are figurative giants. One of them is an actual literal giant. So this is Steve Carlton, my mentor here in Cincinnati. Ron Walls, Rich Levitan, Scott Weingart, Darren Brody, Min Lakong. When it comes to airway management personally, I've really had one original thought in my head in the 13 years I've been doing it. So most of the ideas I'm going to present are not mine, but belong to these fine folks here. I have no conflicts to disclose. I'm not taking money from anybody. So I want you to think for a minute about the last time you had a case of an airway that you had to manage where your sphincter tone was ramped up, either because you were concerned that a bad outcome was about to ensue, or a bad outcome actually did ensue, or the patient decompensated. Maybe the patient even died in the peri-intubation period. Picture that case in your head. What was it that made that case so difficult? Was it a case like this? This is not Photoshop, by the way. A case of difficult airway anatomy, where the patient's vital signs may have been perfect, but their anatomy presented serious challenges to managing the airway. Or was it a case like one of these, where the patient anatomically may have been entirely normal, but they were starting from physiologic difficulty, from marked hypotension, or maybe they were markedly hypoxic, or maybe they were severely acidotic, starting from a pH less than 7. I'm going to venture to say that at least half of you right now are actually picturing in your head a difficult physiology case as opposed to a difficult anatomy case. But the lemon rabbit, he covers both, and we're going to cover both today. So, truths that we hold to be self-evident. First of all, truth number one is that when people encounter the lemon rabbit, they tend to call us. And so we in critical care transport medicine have the privilege of getting to manage a lot of difficult airways. Truth number two, everybody knows Moses came down from Mount Sinai with the 10 Commandments, and the first commandment was, "Thou shalt maximize thy first attempt." We have unequivocal research coming from many different sources. The most recent that I've seen was from John Sackel's group, proving that each additional attempt at airway management increases the risk of complications. So we have got to put all of our efforts into maximizing that first attempt. Truth number three, proven by research by my friend Stephen Thomas, who's in Oklahoma, and Dan Davis, who's at University of California, San Diego, that all of the research that is out there about potential harm of pre-hospital airway management does not apply to those of us in critical care transport medicine and helicopter EMS. Their research has shown us that when we manage airways, we do it well and we improve outcomes. And so we cannot apply all of the research about negative outcomes from pre-hospital airway management to those of us practicing helicopter EMS and critical care transport medicine. And truth number four is that the last time we had a patient box in the peri-intubation period, clearly it was the underlying pathophysiology for which we were intubating them in the first place that caused them to die, right? Maybe. But I would venture to say that some of those deaths were caused by physiology, and that if we manage it with a little more finesse and do everything that we can to manage difficult airway physiology, we can avoid a lot of these really bad outcomes that we fear. So, the lemon part of the lemon rabbit predicts difficult airway anatomy, and more specifically, it predicts difficult laryngoscopy. This is the work of Ron Walls, Mike Murphy, and the fine folks at the Difficult Airway course. And LEMON, as I think we all know, stands for Look, Evaluate 332, Malampati, Obstruction or Obesity, and Neck Mobility. Most of these are fairly self-evident. The look just means take a look at the patient and get your general gestalt of whether or not they're going to be difficult. The 332 rule, we need to remember that this is a rule that is intended to be employed with the patient's own fingers. So don't try doing this if you've got big meaty paws and your patient is diminutive. Use the patient's own fingers. So the first three is mouth opening. Can they get three of their own fingers in between their incisors when they open their mouth fully? The second three is between the point of the chin and the inflection point of the neck. And the two is, can they get two of their fingers in between the inflection point of the neck and their laryngeal prominence, or their Adam's apple of their thyroid cartilage. Malampati, I think we're all familiar with. Obviously, the lower this number, or the better the Malampati, the more likely it is that they will be a good laryngoscopic Cormack-Lehane view. Malampati does overpredict difficulty, but it's still worth planning for difficulty if you're in a class 3 or especially a class 4 Malampati case. Alright, so speaking of cases, let's talk about case number 1. You are called to the scene of a young man who unfortunately is having a tough time in this world, and he is the victim of a self-inflicted gunshot wound. He went intraoral, not submandibular, but intraoral, and he's got an exit wound in the right temple. And you enter the back of the squad, and this man is being held down by EMS. And he seems to really want to sit up, but the EMS providers are concerned about his spine, and so they don't want to let him sit up. And obviously there's a ton of blood, a lot of suctioning going on. He's got a pulse ox probe on his finger there, and you can see that actually his pulse oximetry is in the mid to upper 90s. And he is not hypotensive, he's normotensive. You are 45 minutes away by air from the level 1 trauma center. And so think about how you would want to manage this airway, or would you? First of all, can we let this guy sit up? Well, the answer is yes. Self-inflicted GSW to the head, the odds of him having a significant C-spine injury are extraordinarily low. So I would be fine with sitting this guy up and not placing him into a cervical collar. And with that, you may find that the patient is able to manage his own airway. But the problem in this case is when you sit him up, the man, because he is probably ethanol intoxicated, remains somewhat combative, and again, you're 45 minutes away from a level 1 trauma center. So for the purposes of discussion, let's say that you and your partner decide that you're going to need to capture his airway prior to loading and going. So how are you going to do that? Are we going to do RSI? Shouldn't everybody get RSI'd? Well, judging by these lovely ladies, I would argue that perhaps yes, they should. But let's think for a minute about the Walls-Murphy difficult airway course difficult airway algorithm. Of course, once we've decided to manage an airway, and we have clarified in our head the indication, the first question we're going to ask ourselves is it a crash airway? And obviously in this case the answer to that is no. So the next question we're going to ask ourselves is, do we predict difficulty? And in this case we've got obvious predictors of difficulty judging by the Lemon law. So we have now decided that we are on the difficult airway algorithm. And at first glance at this algorithm, I think we can convince ourselves that it is more complicated than it really is. The basic idea of the difficult airway algorithm is there are two arms. There is this arm that leads to RSI, and there is this arm that leads to awake. Obviously, at any point, if we hit failed airway criteria, we're on the failed airway algorithm, but the two main arms of the difficult airway algorithm are RSI and awake. It is actually common for me to find myself on the difficult airway algorithm, but still to end up at RSI. So we don't need to labor under the misconception that every difficult airway ends with awake intubation. But the key question is right here. Do we predict that if RSI fails, that we will still be able to oxygenate and ventilate the patient by either bag mask ventilation or a supraglottic device? And if we predict that we will be able to do that, and we think it's reasonably likely that intubation would be successful, then we can go ahead and RSI. But if we have reason to be concerned about these, then we need to move down to awake. And I would argue that in case number 1, especially since it was intraoral, a bit of a diversion here for a second. In my experience, and I've never seen research to prove this, but in my experience, submandibular self-inflicted GSWs often turn out to be easier to intubate than you expect, but intraorals tend to be very difficult because both essentially have equal amounts of blood and edema, but the intraoral has an intact mandible, whereas the submandibular typically has a shattered mandible that you can lift forward as much as you want to access the airway. So I would argue that we should intubate this man awake. The great Ron Wall's paradox of when to go with awake intubation is this. When we think we can intubate, we should always paralyze. And when we think we can't intubate, we should never paralyze. This is frustratingly subjective, and yet it is the best, simplest explanation of when to go awake and when to go with RSI that I have ever encountered. So let's talk about some nitty-gritty aspects of actually accomplishing an awake intubation, not in the bright lights of the trauma bay of the trauma center, but in the less bright lights of the critical care transport medicine environment. First of all, a quick plug. One of the greatest rock albums ever made is Awake by Dream Theater. So, nitty-gritty of awake intubation. Who? We've already kind of talked about that. The patient who we have decided needs intubation, they're not a crash, you do predict difficulty, and you have great reason to be concerned about your ability to oxygenate and or ventilate the patient by bag mask ventilation or by supraglottic device, and you're not necessarily convinced that it's reasonably likely that you will succeed by RSI. That's who we're going with awake. It may be a trauma case, it may be an angioedema case, there are other options as well. Alright, so the next question is, are we going oral or nasal? Well, in the current case, I don't think there's any doubt that oral is the correct answer. This guy has, by definition, facial disruption that I think would make nasal intubation too risky. Now, on the other hand, you may encounter an angioedema case where nasal may be your only option. And ideally, nasal awake intubation is done with flexible fiber optic guidance, but that's not going to be an option for the time being in the critical care transport medicine section environment. So I think oral awake is the way we're going to need to go for this case. The next question then is, are we doing DL or VL? And I'm a big advocate of video laryngoscopy, but I do have concerns about its ability to succeed in this case, given all of the blood and soiling of this man's airway. I'm not saying it's not worth a shot necessarily, but it's going to require some major suction if that's going to be able to work. And personally, I would go straight to DL for this guy. Although I will have your back if you go to VL for this guy. I just am concerned that that camera is going to get soiled and leave the video laryngoscope not able to help you. So we, like I think the vast majority of critical care transport programs out there, do not have glycopyrrolate to dry the mucous membranes. We do have atropine. Frankly, I really don't know if it would help or not. If you use glycopyrrolate, all of the advice is that you give it 10 to 15 minutes to work. In a case like this, we're not going to sit around and wait 10 to 15 minutes. If you want to try some atropine, knock yourself out. The guy's already going to be tachycardic, and it may hinder your ability to assess his pupils if you're concerned about his intracranial pressure and potential herniation. So there are downsides of using atropine, and personally I wouldn't mess with it. What I would take the time to do, though, is give 4 or 8 milligrams of ondansetron. And you may be thinking, well, the problem in awake intubation isn't going to be a problem of nausea, it's going to be a problem of gag reflex. And I would agree with you, although there may be some inherent nausea for this guy because he's probably swallowed a great deal of blood. But there is actually now excellent research evidence that ondansetron not only helps with nausea, but actually diminishes the gag reflex. So a lot of folks have added ondansetron to their awake intubation algorithms, and I think that's a great idea. This is a tip I first picked up from Scott Weingart's MCRIT site. Now, this is not a case where a yank hour is necessarily going to be adequate. You need your super sucker. And for those of you that are members of the Air Care flight team, you need to know where the super sucker is. It is attached to the portable suction device, which is right behind the flight dock seat. And this is a case where you're probably going to get enough information in the radio call while you are circling overhead the scene that if you've got your situational awareness about you, should trigger you to think in your head, this sounds like a difficult airway case, and I am going to bring along not only my jump bag and my monitor and all the normal stuff we bring to a scene, but I'm going to take the time to get that portable suction device, including the super sucker, and I would also grab out of that critical care bag the LMAs. Now, ideally with awake intubation, you want to topicalize, and the cardiac lidocaine, which is 2%, is not going to be ideal to topicalize anybody. If that's all you've got, it may be worth a shot. And if all you've got is that and a nasal MAD device for atomization for intranasal administration of something like Narcan, you could probably do a poor man's job of topicalizing with cardiac lidocaine and a nasal MAD device. But ideally, you'd be using 4% airway lidocaine, and you would be using this magic device so that you can topicalize not only the tongue in the back of the oropharynx, but farther down into the airway as well. You do need to keep in mind when you're using 4% airway lidocaine that this is 40 milligrams per milliliter. And so it is possible, if you go crazy with this stuff, to get into lidocaine toxicity. But you probably only need 3 or 4 cc's of this stuff to topicalize somebody. First, in a case like this, where there is an incredible amount of blood within the airway, I would go in with my super sucker, and then I would go in with gauze, and I would mop up as much of the blood out of the way as I could before I topicalized. Now the next question is, what are you going to induce the patient with? Because when we say awake intubation, of course, we don't really mean awake. We mean sedated, non-paralyzed intubation. And in my book, the only agent that we should be using for awake intubation in 2013 is ketamine. Ketamine is clearly preferable to any other agent that you could be thinking about, including etomidate with its 15% rate of emesis, and certainly including Versed and propofol with their respiratory depression and their diminished airway reflexes and their lack of hemodynamic stability. Ketamine has everything you want. The patient will maintain their respiratory drive completely unless you completely push this stuff like adenosine. You don't push anything like adenosine except adenosine. You give ketamine over 30 or 60 seconds, and as long as you do that, they maintain their respiratory drive. They maintain airway reflexes to a degree, whatever airway reflexes they already possessed. They maintain hemodynamic stability. They are not particularly prone to vomit, and it is by far the ideal drug. The other thing about etomidate, in addition to its 15% rate of emesis, is that etomidate does not have the hemodynamic stability that you think it has, especially if you go full dose 0.3 mg per kg. If you cut it down to half dose 0.15 mg per kg, it's pretty hemodynamically stable, but it's no ketamine. Ketamine is incredibly hemodynamically stable, and in fact, a lot of times the patient's hemodynamics are actually increased or improved. Now, the other tip that I've picked up from Seth Truger and Scott Weingart is when doing awake intubation, the ideal way to do it is to have your paralytic out and ready, but not administer it along with the ketamine, but rather just have it ready to roll, and have your bougie out and ready to roll. And then when you get your view, go ahead and intubate the trachea with the bougie. If you couldn't see it go in, confirm that it's in tactilely by ideally both washboarding, which you cannot take to the bank because some people you can't feel washboarding, but what you can take to the bank is the hold-up phenomenon when the tip of that bougie gets lodged at the carina or in the main stem bronchus. And once you confirm that it's in, if the patient is coughing, jumping all over the place trying to fight you, then you can go ahead and paralyze them before you advance your ET tube over the bougie. If the patient's tolerating the bougie just fine, there's no need to paralyze them. But if they're having trouble with it, once that bougie is in and you confirm either visually or tactilely that it's in, there's no problem with going ahead and paralyzing them, because at that point you know you're going to succeed. The problem's not going to be getting that ET tube over the bougie. So there it is in a nutshell, the nitty-gritty of awake intubation in the critical care transport medicine setting. So back to case 1, we decide to go ahead and do that. We suction, we topicalize, we induce with ketamine, we intubate successfully with DL with the bougie. The patient starts really trying to fight us, and so we go ahead and paralyze once he's intubated with the bougie. We advance the ET tube over the bougie. We confirm that it's in with waveform capnography, and the rest of the flight home actually turns out to be pretty boring, except for the cleanup job we got to do in the aircraft once we unload the patient. So nice work on that case. Alright, back to the lemon rabbit for a minute. We know now what the lemon part is about, but what is the rabbit? Well, how do rabbits get around? Do they walk? Do they run? Of course not. Rabbits hop. And the hop killers is a concept developed by Scott Weingart that has really changed my thinking about predicting difficulty in airway management. Prior to Scott coming up with this concept, I, like many people, thought of difficulty basically strictly in terms of anatomy. And this ties in with a concept that Darren Brody came up with a while ago when he changed lemon to lemons, with the S being sat, meaning that a low pulse ox was another predictor of difficulty. And Scott just kind of took that concept further when he came up with the concept of hop killers. So the hop killers are hemodynamic kills, oxygenation kills, and pH kills. And we're going to go through each one of these. Hop patients are patients that you need to intubate who are starting from a distinct physiologic disadvantage. They're starting behind the 8-ball like Spud Webb here. And we need to do everything we can to try and equalize their physiology in order to avoid peri-intubation morbidity or mortality. So let's think about case number 2. This poor lady is having a really bad day. Alright, she feels bad because her urine looks like this. So she decides that she needs to go and visit her doctor to find out what's wrong. And despite feeling very poorly, she's able to get herself ready, and she walks down the stairs from her bedroom, and unfortunately she syncopizes and stumbles and falls and really strikes her abdomen hard on the stair rail and ends up at the bottom of the stairs in a heap with blood in her belly and also a traumatic brain injury. Thankfully, her neighbor hears the commotion, sees what's going on, and calls 911. And the patient is taken by ground EMS to a community hospital where they diagnose not only her urosepsis, but her traumatic brain injury and her intraperitoneal free fluid on a fast scan, and so they call you for transport to the level 1 trauma center. And not only does she have the aforementioned multiple problems, but she has now flipped from her baseline normal sinus rhythm into AFib with RVR to top it all off. So how are we going to manage this lady? On assessment, I will tell you that she's got a GCS of 7. She is oxygenating okay. She's on a non-rebreather in the mid-90s, but not only does she have AFib at a rate of 170, she's got a blood pressure of 66/40. You again have about a 45-minute flight to get her to the level 1 trauma center. Again, she's oxygenating okay. As far as you can tell, she is ventilating okay, but she's got a GCS of 7. So how are we going to manage this lady's airway? Or are we going to try to transport her without capturing her airway? Well, that's a tough call, and many reasonable folks would argue that if we can improve her perfusion and fix this hemodynamic issue, that alone might improve her mental status to the point where we felt comfortable that she was protecting her airway, and thereby we could avoid intubating her at all. So I think it's reasonable, because she's certainly not a crash airway, I think it's reasonable to start off by making some attempts to improve the hemodynamic situation. Now, the first thing that comes to mind for me, I guess ACLS has been beaten into me enough that I realize that whether she just flipped into AFib or whether she's been in AFib for an unknown amount of time, I've got a clearly hemodynamically unstable rapid AFib, and that's something where I might be able to improve the situation by cardioverting her into normal sinus rhythm. Now, certainly this cardioversion may not work, and she may remain in AFib, rapid AFib, but I feel like it's worth a shot. So personally, I would very quickly try cardioverting this lady to see if I could get her back into normal sinus rhythm, because that alone might significantly improve my hemodynamic status. I also need to get preload into this lady. And if she's got good peripheral IV access, great. If she doesn't, and my partner and I can't quickly find some good peripheral IV access, I'm not going to waste much time at all in getting a humeral IO into this lady. And I say humeral specifically because unpublished research from the manufacturer of the EZ-IO shows a 5 times greater flow rate on average with less pain to the patient at the humeral site. And furthermore, any drugs that get pushed through a humeral IO are going to get to the heart and thereby get circulated through the body much faster than the tibial site. So my preferred site would certainly be the humeral head for this lady. And the preload that I would go to in a lady who I know has a positive FAST would be going straight to blood. I'm not going to be waiting for type specific. I'm going straight to the O negative that I carry with me on every flight. Yes, she may need some volume as well because we already said that she is uroseptic as well. But my primary fluid that I would go straight to in this lady, who I've got very good reason to believe is in at least a component of hemorrhagic shock, would be O negative blood. Now, another thing that would be worth a shot in this case, I would argue, is a push dose pressor. Again, this is another tenet of MCRIT, Scott Weingart's material, and it's definitely changed my practice. Between the two options here, epinephrine and phenylephrine, I think there's a clear winner in this case, in a lady who's in AFib at a rate of 170, and that winner would be phenylephrine, because it is a pure alpha agent. It should not increase my heart rate any more than it already is, whereas epinephrine probably will. And so I would go with a push dose of phenylephrine in this lady. Now let's say that we're unable to get her cardioverted. We've got preload going, we've got ONIG going in through our pressure bag, through our humeral IO. We're on unit number 2 already. We've given a dose of push dose phenylephrine, and we're still only at 80/40. And so your partner and you decide that you are going to need to go ahead and intubate this lady. So it might be worth another attempt at cardioversion, because maybe now that you've got a little bit of preload in and a little bit better back perfusion of the coronary arteries after your push dose pressor, your second cardioversion might have a better shot of working. But I think it's time that you're going to have to manage the airways. So how are you going to do that? She's got no anatomic predictors of difficulty. And again, she is oxygenating fine. And let's say, for the purposes of argument, that her venous blood gas that they obtained at the outside hospital actually didn't look too bad. It didn't look too good either, but it's 7.1 with a PCO2 of 32. So although she is metabolically acidotic, it's not the most severe metabolic acidosis you've ever seen. So the main HOP issue that you're dealing with here is one of hemodynamics. Are you going to pre-medicate this lady? You've got some reason to believe that she's got increased ICP. We've already said she's got a traumatic brain injury. So if you would, what agent would you be thinking about using? Well, you'd be thinking about lidocaine or fentanyl for the ICP. Now, what are these things right here? These are small potatoes. And that's what pre-medication is in terms of the research on its outcome benefit. Furthermore, in a case where you're starting from a blood pressure of 80/40 and you're talking about giving lidocaine or fentanyl, both of which can lower the blood pressure, I think that there is a clear-cut risk greater than benefit issue for using pre-medication in this lady, and I would not do it. In general, I've got your back anytime that you decide to withhold pre-medication from a patient, because the outcome benefit is so small potatoes. I've also got your back if you give it to a patient with suspected increased ICP, as long as they are not starting hypotensive. But in this patient, it's going to be hard for me to have your back. All right, what are we going to use to induce this lady? I don't think there's any doubt that ketamine is the way to go. If we're going to manage her airway by RSI, ketamine is the clear winner, even though it may have a negative effect on her heart rate. Again, my friend Michael Frakes from Boston MedFlight likes to say, etomidate does not have the hemodynamic stability that you think it has. Ketamine does have the hemodynamic stability that you think it has, and probably more. So I don't think there's any way we should induce her with anything else but ketamine. Again, we don't want to push it like adenosine. We want to give it slowly over 30 to 60 seconds, but ketamine is the way to go. So we go ahead, after cardioverting this lady successfully on the second attempt, And after giving her a push dose pressor, and after preloading her as much as we are able with a pressure bag and a humoral IO and no negative blood, we go ahead and induce her with ketamine, and we end up post-intubation with a blood pressure that is actually a little bit better than what we started with. She's now up to 85/55, even despite the addition of the positive pressure ventilation. Now obviously we're going to have to keep hitting her hard with the preload, because that positive pressure ventilation clearly has the capacity to increase her intrathoracic pressure and thereby decrease venous return. So we're going to have to watch out for that. But well done. We avoided peri-intubation morbidity and mortality by carefully considering the hemodynamic issues of this lady, which were multiple. All right, case number 3. This is a 2 a.m. Friday night alcohol-induced head-on MVC, where your patient is the driver of this red car, who's a 22-year-old kid, unfortunately ethanol intoxicated, unrestrained, face plant into the windshield and chest plant into the steering wheel. And now you're on scene and you're assessing this guy in the back of an ambulance, and you are alarmed when you climb into the ambulance to see this young man with a non-rebreather that is indeed attached to oxygen, running at 15 liters per minute, and a pulse oximetry of 74%. His hemodynamics actually look pretty good. You quickly assess that he's got some vomit in his airway that the paramedics are trying to suction, and he's got a GCS of 6 at this point. He's 1 for eyes, 1 for verbal, and a 4 for motor, just withdrawing. But he's not combative. So, how do we proceed at this point? Well, the first thought that would come to mind for me is the fact that a non-rebreather, assuming that mask is fitting well, running at 15 liters per minute from a typical wall regulator, is given an FiO2 of about 60, maybe 70%. And a lot of people are under the misconception that if they crank that little ball on that regulator all the way up above 15, that they're still only getting 15 liters per minute. And that is typically not the case. You can actually hear when you crank one of those all the way up, so that the ball on that regulator is bumping off the top of that regulator, that you're actually probably getting 30 liters per minute and maybe even more than that. And when you do that, you increase the FiO2 that the patient is breathing up to probably 90%. And so that is the first simple thing that I would do. Another thought that I would have is that he may benefit from a clearer path for this oxygen to travel down into his lungs. And I'm concerned with the GCS of 6 a little bit about his ability to tolerate an oral airway, but I figure he can tolerate a couple of nasal trumpets. So I would quickly slip a couple of nasal trumpets into this guy. And I would also, he's going to be on a backboard. He's already immobilized, backboard and C-collared. And I would go ahead and elevate that stretcher, the head of that stretcher, so that I'm changing his positioning a little bit, because that can actually decrease the shunt that's going on in his lungs. Assumedly, when you assess this guy's chest, he's got an extremely ecchymotic chest wall because he did that chest plant into the steering wheel. He's got diminished breath sounds bilaterally, but they're equal, and he's got a midline trachea. Nevertheless, it wouldn't be unreasonable to suspect that he could have a tension pneumothorax, and I think it would be very reasonable to go ahead and try needle thoracostomy or a finger thoracostomy even, although that would be a little bit aggressive for a guy who's hemodynamically stable. But at least a needle thoracostomy. But let's say you do that and you get no rush of air, and you get no improvement in oxygenation or breath sounds. So at this point, you're thinking that he probably has significant pulmonary contusion. He may have aspirated as well, and you've got significant shunt going on. And in that case, you can really improve oxygenation quite a bit by just elevating the head of the bed. And a lot of folks are kidding themselves that they can't do that when a patient's on a backboard, when in fact with a little bit of effort they can do it. So oxygenation, the O in HOP, it's all about time. Another one of the greatest rock albums I've heard, at least in the past 5 years, is Rush, Clockwork Angels. And what time is it on Clockwork Angels? It's 21:12. A genius little nugget thrown in by our Canadian friends. Alright, so the oxyhemoglobin dissociation curve. This is what I mean by saying that oxygenation is all about giving yourself time. So you notice that when a patient desats, it's not in a straight line. It is a nice, slow desaturation until the patient gets down in around 90%, and then it is a very precipitous drop-off. And this drop-off doesn't go down at 70 degrees like the Magnum XL 200. It goes down like the Top Thrill Dragster, 90 degrees, straight down. And the other thing that's important to keep in mind is that your pulse oximeter is the world's only true time machine. And what I mean by that is the pulse oximeter is telling you the truth, but it is telling you the truth of the patient's status 30 to 90 seconds ago. It is not telling you the truth about the patient's pulse oximetry right now. And so, when you are intubating a patient, you're doing RSI, you're doing your laryngoscopy, and the pulse ox has descended from a starting value of 99% down to 90, what that means is that they were 90, 30 to 90 seconds ago, and right now, the truth of the matter is they may be down here in the 60-70% range or even worse because of the rate of descent of this curve. And you've also seen, you've definitely seen this in reverse, where you have successfully intubated a patient. You know the tube is in. You saw it go through the cords. You've got the waveform capnography. There is no doubt that the tube is in. And yet, for about 45 seconds, you see the pulse ox continue to descend until it reaches its nadir and then turns around and starts to climb again. And meanwhile, you've got trauma surgeons in the room that are flipping out, concerned that you're not in the airway, and you tell them to relax. It's definitely in. So the pulse oximeter is a time machine. That is the concept of pulse ox lag. And what that means is we should probably be bailing at about 92 or 93% and not at 90%. Pre-oxygenation and Prevention of Desaturation During Emergency Airway Management by Weingart and Levitan. This is, in my opinion, the single most important article published in the emergency medicine literature on any topic in the past 10 years. So please, if you have not read this article, look it up. Shoot me an email. I'll send it to you. I'll send you the PDF, but you've got to read this thing. And we all ought to read it more than once. It's that important. There are so many pearls for dealing with the O in HOP in this article.